all these brothers are meeting just maybe after a couple of days. This is the spirit of Vidyapit, and with this, we start it. I will request if Ritesh can share his screen, that will help everybody to understand our main panelists, Kaushik Mandal, Swapil Gautam, Biswajit Da, and our Dipanjan Haldar. Uh, I There is some issue with the bandwidth. I will just read out. Kaushik Mandal, he is a doctor. Everybody, all the four panelists like. He is MD, MPH, MS, FHRS, FESC, FRCS, CTH. Kaushik is now Director of Cardiovascular Services in Detroit Medical Center. And before this, I knew Detroit only manufactured cars. So, Kaushik, I had been all through associated with automobiles, and glad to know Detroit produces something else apart from cars. So, welcome abroad. Welcome aboard, Kaushik. It's a pride for me. You have joined Vidyapit later than me, but I feel myself fortunate that I got associated with you through this media. We have Dr. Swapil Gautam, who is the consultant physician and most importantly, infectious disease specialist. So all the participants, all the guests here have n number of reasons to make Swapnil talk most. We have most importantly our one of the senior functionaries of Vidyapit Praktani, Dr. Biswajit Sen. Biswajit is a senior consultant pathologist. Now again, one gentleman whom we can always fall back on, whether it should be Covishield, Covaxin, which is better. It is like whether Ram is better or Krishna is better. And finally, we have Dipanjan, who is a consultant hematology and hematochronology. It is a very difficult terminology itself for me. And I remember when I was introduced to him during the initial days of this Vidyapit Praktani, when it was formed in November, this as a executive committee. So he was telling that he is one gentleman. He wishes that none of the Praktani brothers need to consult him professionally. So Dipanjan at such a young age is a star of Vidyapit or Vidyapit Praktani. This evening, all four of them and 44 others will make the session, I am sure, lively. When we end the session, we will be wiser, we will be little more intelligent, and we will be less responsive to WhatsApp propaganda. Maybe at up around 8:35, we may ignore couple of messages and think 30 times before forwarding it. So if that happens, that I will consider this session fruitful. Now it's over to all these four gentlemen whom everybody is eager to listen. And from there on, like earlier two sessions, we are becoming with every session little more intelligent and I am afraid what will happen after 30 or 35 such sessions. Thank you. Over to doctors.
Thank you, Abhijitda, for the kind introduction. I'll be moderating today's session. Kaushikda has already been introduced. So the first talk will be taken by Kaushikda. He will be speaking about COVID-19 vaccines, the international perspectives. So he'll be sharing the basics of the vaccine and what it means to us. Over to you, Kaushikda.
Thank you, Dipanjan. Thank you, Abhijitda, Biswajitda, Ritesh, for reaching out and giving me this very pleasant opportunity to reconnect with Vidyapit Praktani. Vidyapit has and will always have a very special in all of our hearts. So my journey in Vidyapit was between 1980 and 88. Then I finished my MBBS and MS from AIMS and moved to UK to finish my doctoral studies, onwards to US at Johns Hopkins, finishing my advanced fellowship in cardiothoracic and vascular surgery, started my attending career and faculty career there, and eventually was recruited to the car capital of the world, Detroit, to head and establish a program. So you all might be wondering that why do I profess to claim an interest and expertise in COVID, although I'm a highly super specialized surgeon. So I'm starting off with a picture of a mitral valve that I fixed recently using minimally invasive robotic technology, which is my forte. And I've titled my talk as COVID-19 vaccination, Geo or Gene Do. So live and let live. And I will end my talk trying to establish both those responsibilities as to how vaccination plays into it. So I don't have any financial disclosures or conflict of interest related to this presentation. I have to tell you that Detroit was one of the COVID hotspots when the pandemic in US was recognized back in February, March of 2020, along with New York and San Francisco. We were in the midst of the worst hit areas, and especially my hospital, which is in an inner city Detroit location, a lot of poor, economically deprived African-American workers working in the car industry. That's the immediate surrounding community that we care for. So I myself was afflicted, survived, and I'm a frontline health worker. So those are my disclosures. Our involvement during the peak pandemic, when none of the vaccines were there, remdesivir was still not out there, no convalescent plasma was available. Our role as cardiothoracic surgeons in the care of COVID patients is demonstrated here. Patients with COVID acute respiratory distress syndrome who were struggling to maintain oxygen levels and eliminate carbon dioxide. We were trying to help them with ECMO, which is essentially extracorporeal membrane oxygenator. So you can see one of the patients hooked up to an ECMO machine. And this is nothing but an artificial set of lungs that we are attaching. Like dialysis machine, this machine's doing the work of the lungs, and we are just buying more time for the patient's natural immune recovery mechanisms to help them recover. We have reported a 30 to 40% survival with this technique within our center. So that was our involvement. And also a lot of these patients would need tracheostomies because trying to keep them intubated and ventilated, we were needing to douse them with a lot of paralytic and sedative. And a lot of our physician colleagues were very reticent to be getting involved with doing tracheostomies in these patients. So we were offering ourselves. So I probably got infected at some point, but obviously, if you were taking good care of your nutrition and health, you survived through all of that. This is not the first of the pandemics that the world is facing. The first SARS-CoV-1 pandemic raged between 2002 to 2004 with a case fatality rate of roughly around 9.7%. The second one, more deadlier than the first, the MERS COVID, was predominantly localized in the Middle East Turn Belt with a case fatality of almost close to 30%. But somehow in its latest iteration, the virus seems to have struck the right balance between killing just the right number of people. You can imagine whenever there is an infection host interaction, and Swapnil can elaborate more on this, if you kill too many of your hosts, it's like a self-defeating prophecy for the infecting organism. So with a case fatality rate roughly averaging around 5-6%, it's killing just the right number to scare us, yet leaving enough hosts around to still continue infecting and propagating itself. This is a photomicrograph shared by one of my pulmonary critical care researcher friends, Dr. Chung. It's an electron micrograph from a patient B-cell malignancy. And you can see the respiratory epithelium, and these small dot-like projections on the finger-like elongated lung epithelium is the coronavirus studded all around. Now let's come straight down. So I don't want to bore you all with the pathology and the disease. We know how it's manifested. Let's come down to the vaccines, which is the key topic for today. So the currently available worldwide vaccines are as follows: Moderna and Pfizer, both of which are mRNA vaccines. It's the first time that this technology has come to fruition and is being used and has been very successful. Then comes the Astrazeneca Oxford vaccine, which is available in India in form of Covishield, being manufactured by the Serum Institute of India. This vaccine has the same spike protein insert as that of Moderna and Pfizer, but it is developed, it's delivered using a attenuated chimp adenoviral vector, which is how the target immunogen gets delivered. Next is Johnson & Johnson. Again, this is a human adenoviral vector that delivers the spike protein. Novavax, wherein it's a nanotechnology-based spike protein on an adjuvant that is directly injected, prompting body's immune responses to come through. Sputnik 5, which is Russia's Gemlaya Labs adenoviral spike protein construct. And then we have our own indigenously developed Covaxin, which is a whole virus inactivated preparation on a toll-like receptor adjuvant preparation. There are two other vaccines for the sake of completion that needs to be mentioned: the Sinovac and the CanSino, which are the Chinese vaccines. Pakistan, along with China, is running the current efficacy trials for CanSino. The Sinovac trials were run with China and Brazil, which is where they were shown to be barely cutting the efficacy mark of WHO at 52%. 50% was the minimum cutoff required to be considered efficacious. So the Moderna and Pfizer vaccines, based on the initial efficacy trials, and in my next slide, I will go over the nuances just so that you can understand the limitations and how to take the data were around 90 to 95% effective in preventing symptomatic COVID infection. The AstraZeneca Oxford vaccines about 65 to 70% effective. The J&J is about 70 to 75%. Novavax in its current phase 1, phase 2 iterations is about 89% effective. Sputnik V is 91%, and Covaxin in the first planned interim analysis of the currently ongoing phase 3 trial, which hopefully will complete by the end of April, has reported an 80% efficacy. The phase 2 trial just got recently published in Lancet on 8th of March, and it has established its safety profile unequivocally. I want you to focus on this yellow highlighted table, which is titled as Protection from Hospitalizations and Death. And this is a message that is being given by most of our public health agencies. And I want to discuss this a bit so that we are not disappointed, because 100% is too high a mark. And as we know that the uncertainty increases the closer you get to 100%. A quick look at the cost and the storage requirements of these vaccines, and you can then try and factor in as to why each country, why it's deciding one over the other. Pfizer vaccine requires storage in minus 70 degrees Celsius, costs about $20 a shot. You can multiply that by about 70 rupees a dollar to get an Indian equivalent cost conversion. Moderna needs to be stored at minus 4 degrees and is stable, remains stable for about 6 months in that temperature, and 0 degrees normal refrigerator temperatures stable at for about 30 days, costs about $25 a shot. Johnson & Johnson and the Oxford vaccine is stable for 6 months at normal refrigerator temperatures and costs about $10 a shot. No wonder the Serum Institute took it up from a practical nature standpoint, and why this vaccine's in a front runner for Indian scenario and is getting distributed widely in the developing parts of the world. Novavax, which is yet to come out, it's completed its phase 2 studies, stable at 2 to 4 degrees for 6 months. This is the vaccine using the nanotechnology particle platform. And finally, Bharat Biotech, stable at 2 to 4 degrees for 6 months at a significantly lower cost of about $2 to $3 a shot. So coming down to the design of the efficacy trials, there were primary outcomes, and then there are secondary outcomes. And the trialists had to balance the practicality, cost of running the trial and completing the trial in a timely manner to demonstrate at least 50% efficacy. That was the cutoff laid out by WHO and other health agencies like CDC. The primary endpoints that were put out for consideration by these companies were either to show a reduction in symptomatic infection, show a reduction in transmission, or show a reduction in severe disease and hospitalization. Remember, COVID deaths, even in the worst case scenario, it's about roughly anywhere between 1 out of every 500 to 1 out of every 1,000 patient who develops COVID ends up dying. So it's not too frequent an event. So if the companies were designing a trial to show a reduction in severe disease and hospitalization, the sample size in each of the groups would be humongous, and the costs will be a lot. And remember, the companies would have needed to pass those costs onto the government right now, because it's the governments who are of paying for the vaccines, and eventually to you and me as the frontline consumers, and would have made it impractical. Transmission is difficult to ascertain. You keep on swabbing, very difficult to ascertain. So from trying to strike a balance between a practical trial design that can be completed in a timely manner and has enough numbers to give confidence to the regulators, and yet it is manageable from a cost standpoint, symptomatic infections were used as the primary outcome of interest, and that is how the trials got powered. Now remember, all of these vaccines talk about that we are showing reduction in severe disease and hospitalizations. A quick clarification: severe COVID infection and hospital and COVID cases that get hospitalized are not exactly the same. A person who might not have access to afford to get admitted into hospital, very applicable to our country. He may have severe COVID infection because his oxygen saturations are going down. Family has somehow managed to get oxygen and they are treating him at home. Whereas I, with capacity to afford and pay for hospital, and I'm worried that I don't want to be cared for at home, I want to be in the hospital, which can care for all the eventualities, I get admitted even with minor or moderate disease. So they will correlate. There will be a statistical association between these two outcomes, but in the exact terms of the definition, there's a nuance. They're not equivalent. And this is very aptly laid out by the trial data. In the Oxford AstraZeneca trial run in Europe, one person out of the control group had severe COVID, defined by reduction in their oxygen saturation, but 8 patients were hospitalized. In the Johnson & Johnson trial, 34 patients had severe COVID based on the decreased oxygen saturation definition, but only 5 were hospitalized, okay? As far as the trials themselves were concerned, only 3 trials actually collected data on severe infection and hospitalization. The Oxford AstraZeneca trial, the Johnson & Johnson trial, and the Novavax trial that is currently ongoing. The Pfizer trial, the data that was submitted to FDA for the emergency use authorization did not collect data on severe COVID infection and hospitalization. Same thing is applicable for Moderna. The age groups involved in the trials usually 16 to 60, 65. None of the Moderna or Pfizer trials included patients at the extreme, so like 80 years old. Those with severe comorbidities had limited representation. However, since the start of worldwide vaccination, there are very encouraging publications that have come up. The recent paper in JAMA from detailing the experience in Israel, comparing 600,000 patients who received the vaccine across all the age groups going all the way up to 80 versus 600,000 chosen controls. This is a real world data, not a randomized trial. And it was good to know that the vaccine indeed is effective. The efficacy is not at 94% plus as shown in the initial submitted trial data. It's around 88%. Perfectly happy with it. More importantly, it also has been shown to reduce transmission. Vaccinated people do not transmit the virus as readily as non-vaccinated individuals. The data from Scotland, UK, after single shot of Pfizer or Oxford AstraZeneca, i.e. Covishield, was clearly demonstrated to be effective in reducing serious COVID infection and reducing hospitalization in octogenarians, elderly people. So now, so when you see a company or a public health agency touting the 100% efficacy in terms of reducing hospitalization and preventing serious COVID, take it, don't distrust the data. They're trying to encourage you, but nothing is in a biological system ever approaches 100% efficacy, never. And so you may still get COVID, but what is 100% assured that you are unlikely to have serious COVID consequences or die as a result of COVID infection if you've taken the vaccination. Now, quickly running through the special considerations, the trials did not include children below the age of 16. There is a current Pfizer trial running, evaluating its role in the age group of 12 to 16. We should see the data by the end of the year. As I've already alluded, elderly patients were not included in the trial, but we are seeing encouraging data supporting the vaccine efficacy in that subgroup from the real world data. Allergy has been a big concern as the vaccines have got rolled out. Now, to put things in perspective, any other vaccine, we have survived to this adulthood having been vaccinated. We've received BCG, we've received polio, DPT, God knows how many. As a broad rule of thumb, the risk of anaphylaxis and serious adverse events with any vaccination is about 1 in 1 million. The risk of anaphylaxis with COVID vaccines is high, is about 10 times higher than any other vaccine. It's about 1 in 100,000. But keep in mind the risk of death from COVID, if you were not to be vaccinated, is 1 in 1,000. So you still, even if you were to take the vaccine, you're 100 times more likely to benefit rather than be harmed by the vaccine. Dipanjan will dwell upon this special group of patients, those who are immunocompromised, especially those by virtue of their innate cancer or the treatments that they're receiving. Their B cell population, the cell that drives the antibody production, is depleted. They remain at special risk, but even there, the recommendation is to get the vaccine, unless you've just received a dose of a drug like Rituxan, which depletes your B cells. Then there are recommendations to delay, but not avoid. Patients with cardiac, renal, liver conditions, everybody benefits. We have seen more deaths during the peak COVID pandemic in the Detroit community. There are papers abounding all over the world that more patients died during that period, not because of COVID, but because patients were so scared to come into the hospitals that people ignored their heart attacks, people ignored their strokes, and they died of those conditions at home rather than COVID. Patients with prior COVID infection, current CDC recommendation is people who have recovered from COVID and they're past 3 months from their infections should get the vaccine jab. There was a recent paper just 4 days ago that came out in the New England Journal of Medicine. What they're showing is that patients who've had a prior antigen challenge by virtue of the exposure to COVID infection, they mount a much quicker antibody response, even to a first dose, And the paper threw out the possibility that for these particular people, could just one dose be enough rather than two doses, something that needs to be established with more robust data, but an interesting observation. And in my own case, I've monitored my own antibody profile as I recovered. My infection was in March of 2020. By the time I was coming to November of 2020, my antibody levels had dwindled to non-detectable. They had peaked at 3 to 4 months post-infection. So I did get my 2 shots of Moderna vaccine in December once it was being offered through our hospital system. There will definitely be need for further booster shots, pretty much along the lines of the flu vaccine. It's yet to be determined, so please watch the space out. The variants that are rapidly emerging, it's a battle. The virus wants to survive and we want to survive. And B117, B1351, P1 from Brazil, it just basically says that every country needs to optimize the use of its laboratories to have a sero-epidemiological surveillance plan in place to monitor for these emerging variants so that the data can be passed on to the vaccine manufacturers and they can then incorporate those antigenic shifts or drifts in designing the booster shots as it keeps on coming. COVID is a reality. We have to learn to live with it. We have to keep on taking a booster shots, just the way I take my annual flu shots so that I can still continue taking care of my elderly immunocompromised patients. It's just another vaccine that gets added on to my list. There are religious contentions amongst the Christian groups who the anti-abortion lobby, because the J&J and the Oxford Astrazeneca vaccine, any adenoviral vaccine is generated and developed through aborted fetal cell lines. But I don't want to hurt anybody's sentiments. You just have to make the wisest and the best decision for yourself. And finally, there has been a lot of hype, a lot of paper articles that I read about, has India achieved herd immunity because of the dwindling case numbers? For whatever it's worth, if you were to rely on the validity and the accuracy of the reported data,
Kaushik, please conclude.
Yep. Finally, so if look at this slide from Manaus in Brazil, that pretty much had its peak. The infection numbers dwindled down, and as they relax their restrictions, social distancing and masking restrictions, they're again going through a peak. We are exactly seeing the same thing in Nagpur, in Maharashtra, Delhi, Haryana, and lockdowns are again being considered. So I don't think herd immunity without vaccines is a reality. So we should get vaccinated. So in summary, get vaccinated or decide to live inside a bubble forever. Economically, the world cannot survive like this. So I would urge everybody to get vaccinated. And the best vaccine is the one that's available to you. Thank you.
Thank you, Kaushik, for the wonderful talk. And I think your last sentence, the best vaccination is the one that is available right now, summarizes it all up beautifully. Now the next speaker, we have Dr. Swapil Gautam. Dr. Swapil Gautam is an infectious disease specialist, and he will be talking about the vaccine, COVID vaccine in terms of Indian perspective. What are the Indian vaccines available to us? Should we choose between them? And such kind of things. So I'll be sharing the screen on behalf of Dr. Swapnil. If the host can please allow me to share my screen. Dr. Swapnil, are you able to share the screen from your end?
No, Dipanjan, I need your help.
Sure, sure. I'll share. So, yeah, so I can share it now. Yeah, right.
Yeah. Before I start, in the meantime, I'd like to thank our Vidyapit brothers to give me this opportunity to come on this Adda and give some talk. It is really heartening to be on the same platform as my elder brothers and my juniors. I really want to thank all those who have taken this effort to organize this talk, especially to Dr. Dipanjan, who was after me to prepare slides. Sorry, Dipanjan, if I was too late. I hope you can understand. And it is I was not able to respond to all the emails and messages, and sincerest apologies. So you can understand what we are going through being an ID consultant. So please pardon my late Latifi. Anyways, I'll just dive in fast.
So next 5 minutes or so, over to Swapnil.
Yeah, I'll try to feature fast because I think Kaushik has done wonders. He has made my job quite easy. It is easier for me to talk now, and he has especially mentioned all the points that we need to clarify. So as Dipanjan rightly said, I'm just going to talk about two vaccines that we have in our country, India, and some experiences and what about they are. So first is Covishield that we're getting through obviously from Serum Institute of India, and it is from the Oxford Astrazeneca home, and they got the license, and the Serum Institute is basically preparing this and distributing. The good point is that our country is providing this vaccine at a cost of around just 250 rupees. So it is a very, very low affordable price. So basically it is a recombinant replication deficient chimpanzee adenovirus vector, which has the spike protein of SARS-CoV. So this as spike protein expressed locally, which stimulates neutralizing antibody and cellular immune response. So this is how this vaccine is working. So there's only one protein which is active here. There's a spike protein. What are the guidelines from Indian government right now? So obviously there are too many papers, as Dr. Kaushik was talking. So I'll just talk about what the Indian government guidelines till date are. So it is basically advisable for immunization of individuals more than 18 years, not less than that, because we know that the safety efficacy data is not that much. There are two separate doses of 0.5 ml IM deltoid, as all the vaccines go in deltoid, and there is 4 to 6 weeks gap is advisable. Obviously, now we can see from the study that was done earlier that if up to the gap of 12 weeks, we have a more generation of antibodies. The protection is better. And the most important point is that the second dose must be the same as Covishield. So we cannot jump from Covishield to Covaxin in either way. So people have a habit of window shopping here, at least in India. But here the guidelines are very straightforward that if you have taken the first dose of Covishield, you have to go for second dose of Covishield. Now, only the major contraindications are hypersensitivity. So hypersensitivity to any constituents of the vaccine, Covishield, I think it contains L-histidine, some magnesium, all those things. In my personal experience, I have just noticed 2 or 3 very severe reactions to the Covishield, where the patient had to be admitted, given some steroids and IV foods, the patient BP had gone down. Otherwise, it has been tolerated well. If a patient has a acute severe illness, then better to avoid. Minor illness like cold, cough, you can take this vaccine. Then they have to be cautious as low platelets, anticoagulants, coagulation disorder. This is the patient who needs to be a little bit vigilant, and you need to take and speak with the doctor whether you can take the vaccine or not. Their guidelines are there on this also that we can discuss on the panel part. Next slide. Again, the concomitant administration of other vaccines, not studies. Many times patients do land up and they ask whether they can take some other vaccine with this COVID vaccine. Still, there is no guidelines, but generally 2 weeks gap can be kept. The limited experience with pregnant women, true. In the pregnant women, we have to decide about the benefit risk ratio. Now, some studies are coming from pregnant women, and I'm sure it is safely can be given to pregnant women, but not a clear guidelines have come from Government of India to allow vaccination of pregnant women. All this data has come from these 4 clinical trials, as Dr. Kaushik was talking. This is an interim analysis. The important point here is to remember that WHO published this data, whatever the data they got till that was from 7th till 7th December. So it was too early to get all these things. It was too early to accumulate all the data. So whatever recommendations, whatever efficacy was there, it was just up to the 7th December 2020. So as time is progressing, we are going to accumulate more data, and there be some changes in the efficacy and other indications or whatever. So most frequent adverse effects is injection site tenderness. Oh my God, I had pain for 4 days when I got that injection. And then there is a fatigue, malaise, headache, myalgia, fever, nausea. So these are common things that I observed in my patients who have taken this vaccine. Otherwise, it is very, very self-tolerated. It's a very minor, that is expected of any vaccine to cause some minor adverse effects. And in India study also, it has been very much safe and well tolerated. And as per the Serum Institute of India, the protective immune response comes 4 weeks after the second dose. Next slide. Yeah, this is the Covaxin, which is the darling of all the Indians because it is the India's indigenous vaccine, which is developed by Bharat Biotech with a ICMR collaboration and NIV Institute, that is National Institute of Virology from Pune. So here they are using a whole virus which is inactivated. So they are using a complete virus, not a specific protein. So advantage is that they can use this vaccine against all the variants because it's not a specific protein. But still, it is a speculation. We don't know. So as we go ahead, we get more data. Then we can talk about what is the how to modify the vaccine so that it can use for booster immunizations. Again, 2 doses, 4 weeks apart. It is stable at 2 to 8 degrees. See, India has limited, we can say, logistical issues, limited logistical availability. So those vaccines you can store at this 2 to 8 is very easy. So if you don't need to have a very much different kind of refrigeration to use vaccines like your Pfizer and Moderna. Then the phase 3 trial, 81% efficacy. See, I don't go by too much of efficacy because I say these are very too early to determine. So whatever is crossing the 50-52% of the threshold can be easily be used. And whichever vaccine you are getting, you should get yourself vaccinated. Very used. And it is a restricted use in emergency situation. So all of these 2 vaccines where obviously they have been approved for restricted use in emergency situation. So that's why our local pharmacy where I don't have this vaccine. Next slide. Yeah. So this is a vaccination drive. It was the largest vaccination drive all across our world by our country. It's the launch of 16th of January 2021. The first group were healthcare and frontline workers. And now the second group has been started, I think from the 1st of March. Those who are more than 60 years and 45 to 59 years with comorbid conditions. So they are being vaccinated. They are being vaccinated with the help of COVID. You can go to the internet, you can go to the COVID site and apply for your registration and accordingly get the place where you can get yourself vaccinated. Or you can use the Arogya Setu app. And my personal experience, the services and arrangements have been too good. It's too good to be ignored. Very nice, very nicely done with all the supports and efforts have been done. Maybe there has been some hitches and glitches in the first few days, but overall, this arrangements for vaccination and all these vaccination centers have been done quite remarkably well. Now, the private hospitals have also been allowed, at least in our city of Mumbai, at least I think 20-25 hospitals are already doing it, more to join in. And now it is going to become 24/7 vaccination to hasten the rate of vaccination. This from data from as of 13th March 2021, 8 a.m. So this is the people who have been vaccinated. So almost 3 crore people have been vaccinated till now. Next slide. So I like to thank here, and it has a very short talk because I just discussed 2-3 slides, because basically I wanted to apprise all of you about what are the vaccines are available in India. And as we go ahead and when we can discuss head to head and any questions, any queries, that will be the best time So we can take questions at that time. I hope Dipanjan will agree we can take questions at that time.
Sure, Swapnil, that was wonderful, very short and crisp presentation. Since we are running a bit short on time, what I'm going to do is I'll be discussing the myths versus facts on COVID vaccine. So this is generally I prepared like basic what are the most commonly asked questions, and we do have some audience questions which I will be requesting the panel to be taking at the end of this talk. So the first question is, what is the effectiveness of vaccines, like COVID vaccine? What is the effectiveness of it? So this Kaushik has already covered. So all the vaccines are actually 100% effective in preventing death and severe COVID infections. So like overall, they're extremely effective in preventing serious COVID infection and death. They do have high to moderate efficacy against symptomatic COVID. However, they have poor efficacy only against asymptomatic COVID. So whenever you're choosing a vaccine, actually you should not run after the efficacy data, because most important is preventing death from serious COVID, and for which all the vaccines are almost 100% effective. Whether everyone should get vaccinated? Yes, definitely everyone should get vaccinated, because vaccine prevents serious infection and death, and everyone should themselves get vaccinated and encourage others to get vaccinated. Now coming to the third question, whether pregnant ladies can be safely vaccinated. So yes, vaccination of close to 10,000 pregnant ladies has been carried out in the United States without any significant side effects seen up to 3 months of follow-up. So yes, although in the pregnant ladies, the data is not robust, pregnant ladies can be safely vaccinated. Moving on to the fourth question. Again, this is a very common question that people have. I'm allergic to this food, I'm allergic to that drug. Whether should I get vaccinated? Whether I can get vaccinated? So yes, people with allergy to food, drugs, latex, venom, previous non-COVID vaccine can safely take COVID vaccine. However, only people with severe anaphylaxis. Okay, so severe anaphylaxis is like extreme form of allergic reaction. So only people with severe anaphylaxis to previous COVID or non-COVID vaccinations should or non-COVID vaccine should avoid the taking COVID vaccine. Mild allergy to food or any drugs is generally not a big deal. When to vaccine post-COVID? So again, this was covered by Kaushik in his talk. So suppose you are having a COVID infection, when should you take vaccine? So people who have had COVID in past must go for vaccine post 4 to 6 weeks after recovery. And the data is presently emerging that they might just need one shot of vaccine, as robust neutralizing antibody titers and strong T-cell responses have been found in them even after single shot of vaccination. However, this has not been documented in larger studies. So long story short, if you're having a recent COVID infection, you should wait for about 4 to 6 weeks post-recovery before taking the COVID vaccine. What about if somebody has received plasma therapy for COVID? Should they get vaccinated? Yes, somebody who has received plasma therapy for COVID, they also should get vaccinated, but generally they should wait at least about 4 weeks before taking the COVID vaccine. If suffered from severe illness, so those people who are suffering from severe illness, any non-COVID illness, whether they can get vaccinated? Yes, people who are suffering from severe disease, if like they are admitted in the hospital for some other cause, they should wait for at least 4 to 10 weeks after recovery before taking any vaccine. Few points about diabetes and vaccine. Again, this is a very common problem, a very commonly asked question. I am having diabetes, whether I can take the COVID vaccine. So yes, diabetic patients can safely get vaccinated. They should go for vaccination after taking the food or breakfast. In fact, diabetes patients should get vaccination as priority, because they are at higher risk of infection and at high risk of severe COVID. Antibody response to the COVID vaccine may be slightly impaired in the diabetics, but again, no study has been done for this so far. So basically, a diabetic patient should get vaccine in whatever band that is available at earliest, and they can get safely vaccinated. Again, a very commonly asked question, and someone from the some audience have also asked this. So whether if the patients, they are on steroids, whether they are on immunosuppressants, or if somebody is having asthma, whether they can get vaccinated. So if someone is on steroids, so ideally, if it is possible, they should consult their physician to decrease the steroid, that is prednisolone dose, to less than 7.5 milligram per day, if feasible. before taking the COVID vaccine, because higher dose of steroid generally impairs the immune development to the COVID vaccine. If somebody is on inhaled steroids, so many times we see the asthma patients, they are on inhaled steroids. So for patients on inhaled steroids, this should not be need not be tapered prior to taking COVID vaccine, because the systemic viability of inhaled corticosteroid is extremely low. What about patients of bronchial asthma? Whether they have any danger to take the COVID vaccine? No, they do not have any such danger, and bronchial asthma or skin allergy patients can get safely vaccinated. What about patients who are on immunosuppressants? So many times we get patients on rheumatoid arthritis or again such collagen vascular diseases or on immunosuppressive agents. So yes, they can also get vaccinated, but if possible, they should consult their physician to especially to stop methotrexate 2 weeks prior to vaccination and 2 weeks after vaccine if that is feasible. Kaushik was also talking about rituximab. So again, that is a immunotherapy agent. So if possible, 4 weeks gap from rituximab is considered ideal. If planning to undergo surgery, again, a very commonly asked question, I'm planning to undergo surgery, whether I can get vaccinated. So yes, if planning to undergo surgery, definitely those such people can get vaccinated. So if possible, they should take their vaccine, in fact, 2 weeks prior to surgery, so that when they're going for the surgery, they do have a good titer of antibody to prevent themselves from COVID infection. Again, a practical problem, what about patients of kidney failure, heart failure, or liver failure, whether they can get vaccinated? So definitely yes, stable patients of chronic kidney disease, heart failure, liver failure, all these patients can get vaccinated and ideally should get vaccinated, because the risk of them having severe COVID infection is much higher. But having said that, their immune response may be poor. So they might not be developing robust antibody response, but definitely they should get vaccinated. Again, a very commonly asked question, I'm on blood thinner. So blood thinner, when you're talking about, there are two types of blood thinners. One is antiplatelet and another is anticoagulants. So what if the patient is on blood thinner? So for example, if many times patients are having heart attacks, so they are taking ecosprin, clopidogrel, such kind of antiplatelet agent, whether they need to stop these agents prior to vaccination. So no, people taking aspirin and clopidogrel need not stop these drugs prior to vaccination, and they can definitely get safely vaccinated. Sometimes patients are on anticoagulants. So anticoagulants are a bit stronger type of blood thinner. They have a different mechanism of action. So whether the patients on anticoagulants can get vaccinated? Yes, patients even on anticoagulants can get vaccinated. Unless, of course, they are having active bleeding, or sometimes when patients are on a blood thinner called as warfarin, if their blood is extremely thin, which we measure by a test called INR. So if their blood is extremely thin, that is INR more than 3, then they should decrease the warfarin dose, and the INR should be at least between the range of 2 to 3 before going ahead with COVID vaccine. But long story short, people on most of the blood thinners can get safely vaccinated. So this was about the most commonly asked questions that I had prepared. We do have certain questions from the audience as well. So this I'll be taking ahead in the form of panel discussion now. And so these are certain questions that have been put forward.
Dipanjan,
হ্যাঁ দাদা বলুন।
আমার একজনের ক্লোজ রিলেটিভের সিওপিডি আছে, তা ও কি ভ্যাকসিন নিতে পারে?
Biswajit, I request all the panelists, Kaushik da, Biswajit da, and Swapil da, to please unmute themselves.
আচ্ছা আচ্ছা,
One of them can take up the question. Biswajit da, can you please take up?
Can you please repeat the question, Premananda da?
বলছি যে আমার একজন রিলেটিভের সিওপিডি আছে।
Yeah, I think there is no contraindication in taking the vaccine for people having chronic obstructive pulmonary disease.
So he can easily take it.
Yes, they should.
Dada.
They should actually.
They should take on a priority basis.
Yes. Dipanjan.
আরেকটা যখন ওটা জিজ্ঞেস করেছিলাম, ওই আমার বউ কি ওখানে নেবে না এখানে এসে নেবে?
Yeah, so I'll just sum up what Dada is asking. So Dada's one of the relatives has taken one vaccine in India, and she is migrating to US. She is moving to US. So Dada is asking whether she can take the next vaccine in US. So my personal recommendation would be not to do that, because it is always the second dose is recommended of the vaccine which the person has taken the first dose. It is advisable not to do a mix and match, because as Kaushik that shared, like all the vaccines, they have got a different mechanism of action. Their bioconstruct is different. So it is advisable not to do a mix and match and play with the immune system, because then it will end up being a khichdi. So that is actually not advisable.
Thank you. Thank you.
Dipanjan, I saw in the chat one question was asked by Anuj Kalra, if I'm not mistaken.
Yes, Anuj Kalra.
Yeah, Anuj Kalra. He writes that in Italy, they have recommended him to take the second dose after 12 weeks. So I think he's correct, because the recent publication, I think it has come in Lancet. They have seen, the Astrazeneca people, they have seen that if you increase the second dose from 4 weeks to 12 weeks, the antibody titer is much more. So, because the data which you are getting is basically a 4 weeks data, and the efficacy rate after 12 weeks, they are showing it to be about 82.4%. This is a recent publication. That's why they are prolonging the second dose.
Can I also raise a point, Dada?
Yeah, please.
Definitely the efficacy data in support exists, but also remember, whenever a vaccination schedules are being made, it's a public health policy.
Yes.
And public health policy is different versus when I am recommending a decision to you as an individual, and a one-to-one decision making is not the same as when decisions are being made for millions of people.
Exactly.
So vaccine availability is also an issue. So you can imagine that if they prolong the gap between two vaccines from 1 month to 3 months, they have lot many more dosages available to vaccinate lot many more people. And it's a public health decision whether you would have more people protected with a single dose vaccination versus having less people protected more robustly with 2 doses of vaccination. So that's a public health decision, and each country is going to make their own decision.
Their own decision, exactly.
Can I say something?
Yeah.
Yes.
Thank you both for your replies, really. Also in Italy, like I got the AstraZeneca, and here there were like a couple of cases wherein AstraZeneca came into news because in Sicily there were like 2 deaths, and it was in the news that it was AstraZeneca, the vaccine in use, and they put a hold on this batch of AstraZeneca. But at the end, it was found in the autopsy that also the people concerned, they had previous health issues, severe cardiac issues. So again, that batch is still on hold, but AstraZeneca also is still functioning. So I just wanted to reiterate that even knowing all these facts, I went ahead and I got the vaccine. So I also wanted to reiterate that yes, everyone should. I feel myself lucky. I'm just 31, and because I'm a doctoral student here, the Red Cross was carrying out this drive to get the vaccine, and I volunteered to get it. Yeah.
Good.
Yeah, I think so. There were questions mailed to us before. So there is one question like whether cancer patients can take vaccine, like somebody above age of 50. Yes, definitely cancer patients should go ahead with vaccination. And somebody has asked, is it safe for people with CLL, that is chronic lymphocytic leukemia, to go ahead with vaccination? So yes, even patients with chronic lymphocytic leukemia, that is CLL, should go ahead with vaccination. Of course, in patients with hematological malignancies, their immune response development, that is the antibody titer development, post-vaccination might not be as robust as compared to normal population. But definitely they should go ahead with vaccination, and again on a priority basis. So when Government of India has prioritized patients with leukemia, lymphoma, and such kind of blood cancers to go ahead with vaccination. Somebody had asked his father is about 83 years and is on taking tablet Acitrom daily. So what should he do pre and post COVID vaccine about the blood thinner? So as I was mentioning that, yes, Acitrom is basically a type of anticoagulant. That is, in a layman's language, it is like a stronger type of blood thinner. So we do monitor a test called as INR, which measures how thin the blood has become. So So definitely if the blood, if INR is between 2 to 3, the patient can safely go ahead with vaccination, did not hold any dose of azithromycin prior to vaccine. After taking the vaccine, if the patient is on blood thinner, just needs to give a firm pressure on the site of vaccination. So that's all about blood thinner. But if the INR, that is, if the blood is more thin, that is more than 3, then in such case, we need to dose titrate the azithromycin or the blood thinner to reduce the to make the blood less thin. And once it becomes less than 3, so then they can safely go ahead with vaccination. So these were some of the questions.
Dipanjan.
Yes, there is a question in the chat box which probably you can take up.
No, before I go in the chat box, I just wanted to, can you just elaborate to the audience over here? You see, there is people do not understand, blood thinner is a very layman's term, right? So if you really see, basically the doctors want to make the blood less coagulable, right? So there are two basic platforms. One is the antiplatelets. The other is the anticoagulants. They are two entirely different things, because antiplatelets like aspirin, is very commonly used. That has nothing to do with INR increase or decrease, right?
Sorry to interrupt, Dada. That was my question actually.
Okay.
My father, Amitabh Ghosh, 86 batch.
Okay,
Jara. My question. Like,
yes, if you are.
It is my father. It's related to my father. Doctor who is seeing him, he said that like you don't need to take anything. You can go ahead and take the vaccine. So I was wondering, like he's with he's an elderly person staying alone in Calcutta, and I'm staying in Pune. So he's alone there, and he's under elderly people care around there. I have arranged for him. So he said to me, like the elderly people care said that, your Baba needs to be off that medicine for 2-3 days before taking the vaccination. So that was my challenge to me. Like I was totally perplexed.
দাদা অ্যাসিট্রম যদি নিয়ে থাকেন আর আইএনআর বলে একটা টেস্ট করা হয়, সেটা যদি 2 থেকে 3 এর মধ্যে থাকে বা 3 এর বেশি যদি না থাকে, তাহলে ওষুধ বন্ধ করার দরকার নেই। অ্যাসিট্রম খাওয়ার সময়কালীনও নিতে পারেন ভ্যাকসিন।
না তাহলে মানে ওই আইএনআর টেস্টটা আমি করিয়ে তারপরে
হ্যাঁ ডেফিনেটলি। সো যদি লাস্ট 1 মাসের মধ্যে টেস্ট না হয়ে থাকে, ডেফিনেটলি একবার করিয়ে নেবেন।
না করেনি, 1 মাসের
মধ্যে না হয়ে থাকে করিয়ে থাকেন। বিশ্বজিৎ দা জি কথাটা বলছিলেন ব্লাড থিনার। সো মোস্ট কমনলি যেটা ইউজ হয় ইকোস্প্রিন, ক্লোপিডোগ্রেল ইত্যাদি টাইপের ব্লাড থিনার ইউজ হয় হার্ট অ্যাটাক পেশেন্টদের জন্য বা যাদের অন্যান্য কোনো কার্ডিওভাস্কুলার রিস্ক আছে তাদের জন্য। তো ইকোস্প্রিন বা ক্লোপিডোগ্রেলের সঙ্গে কিন্তু ভ্যাকসিনের কোনো কন্ট্রাইন্ডিকেশন নেই। পেশেন্টরা যারা ইকোস্প্রিন বা ক্লোপিডোগ্রেল নিচ্ছেন তারা ডেফিনেটলি ভ্যাকসিনেশনের জন্য যেতে পারেন। তাদের কোনো ইকোস্প্রিন বা ক্লোপিডোগ্রেলের ডোজও বন্ধ করার কোনো দরকার নেই।
আমি পুনাতে আছি, আমিও ডায়াবেটিক, তো আমায় তাড়াতাড়ি নিতে হবে তাহলে।
আর আরেকটা ক্লারিফিকেশন, the risk is only যে ইনজেকশন সাইটে ব্লিডিং এর চান্স একটু বেশি যারা ব্লাড থিনারে আছে। ডেথ, স্ট্রোক, হার্ট অ্যাটাক, কিডনি ফেলিয়ার এসব কিচ্ছু হবে না। আমাদের কার্ডিওলজিস্টরা পেশেন্ট যারা ধরুন নানান অ্যাবলেশন প্রসিজারের জন্য আসে, তারা ওয়ারফারিন না বন্ধ করে INR 2.5 এ they are poking their femoral veins and arteries for doing catheterizations and other things. So সুতরাং it's not, the only risk is a slightly higher chance of a hematoma injection site. That's it.
Kaushik, but that can also be avoided because the needle which is being used is 23 gauge. It is very thin. Nothing happens.
Exactly.
But
very true.
Dipanjan, I see in the chat box one question which is also commonly asked these days.
Thank you very much for your help.
Aditya is writing, will these vaccines be effective against the newer mutations?
Swapnil can take this up.
So Swapnil,
what's your take?
I will bet my money on Covaxin to work more against these newer variants, because if you go theoretically, this vaccine just contains the spike protein. This word, this is uttered by the sentence. At the same time, I'd like to say that it's too early to comment on this. As we go ahead, we need to get more data, and go ahead. See, if we can go a few weeks back, we know that this vaccine, AstraZeneca vaccine, was not working against the mild infection of the South African variant. So it was returned back. So it is too early to comment out anything, but one advantage Covaxin here, at least theoretically, is still too early. Please mind that it may work against all the variants because it contains the whole inactivated virus.
Yeah, Swapnil, I just heard 2-3 days back, you must be knowing Samiran Panda. He is the chief of, I think, Indian some viral research institute. Actually, they are saying, it has not been published, that they have tried the, after giving Covaxin, to test against the UK variant. And they have seen that neutralizing antibodies against the UK variant has been.
I have seen that. I've seen that paper from Dr. Ella, the husband and wife team that owns and runs Bharat Biotech.
Yes.
They published an in vitro data on cell lines looking for neutralizing antibodies against these variants, and Covaxin was shown to neutralize the viruses. So that in vitro data does exist. And as Swapnil says, that theoretically, because it's a whole virion preparation, quite likely the body is likely to mount antibody generation against a whole bunch of epitopes. So you're less likely to have an escape versus the spike protein design, which will warrant a modification of the viruses, just like the flu viruses. Like every season, you look at the commonest antigen types for the last year and then design the next year's vaccine. So for the mRNA, they have to do something along those lines, probably.
Absolutely. So I'll quickly take up. I can see some questions in the chat box. So Dr. S.K. Sinha is asking, if a person is diabetic, hypertensive on low dose ecosprin and had undergone minor cardiac surgery, can he take the vaccine? Yes, definitely. He can go ahead safely for the vaccination. There is absolutely no problem. Second question is, like, what is the criteria followed for judging efficacy of vaccine? Is it just antibody titer or something else? Is the same guidelines followed to test efficacy of all the vaccines developed? Biswajit can take this up, or maybe Kaushik. Criteria for judging efficacy of vaccine, is it antibody titer or something else?
No. Antibody titer only tells you that your body has responded to the foreign antigen. That's it. Now, whether these antibodies are protective antibodies or whether these antibodies are non-protective antibodies, those has to be done in research institutions. You see, let me give you one common problem which we are facing in Delhi. Now, many people are getting themselves tested for the antibodies after the vaccination, before the vaccination, for whatever reasons. Now, you see, we are conducting a small trial inside our own lab. It's about 200 of our doctors and technicians who had suffered from COVID, who had not suffered from COVID, their pre-COVID antibody infective titers, antibody titers, as well as pre-vaccine antibody titers after the first dose and after the second dose. So we will collect the data. But in short, what we have seen is that people who had suffered from COVID, proven COVID, their antibody titers after the first dose is very high. And compared to the ones who did not suffer, the antibody titers after the first dose was also raised. But after the second dose, the antibody titers were remarkably high in both. And this is, most of us over here have taken Covishield because Covishield was given in the private. But one thing I want to, because there was some controversies, some of my friends, doctors who had taken the Covishield, they came and told me we don't have any antibodies. I said, it cannot be, something must be there. So you give the blood sample to me. So we did it, and the antibody titers were high. So I asked from which laboratory you are doing. And the most important thing for the general audience, I want to tell you, if you are going for the antibody test, please ask them what antibody they are testing, against what. It is not only I am doing IgG antibody or IgM. No, against what is it? The best thing is if the laboratory is doing an antibody against the spike protein. There are two spike proteins, spike 1 and spike 2. And within the protein, they have the receptor binding domain. And if you are developing antibody against the spike protein, probably it is a surrogate marker that these will be probably neutralizing antibodies. The test for neutralizing antibodies is different.
Dada, I would appreciate like if you share this in the chat box. I'm staying in Pune.
Okay.
And you know, like whole across the area is totally, we can have any lockdown, but hopefully not. Nagpur is already in lockdown right now.
Hello.
And, what test we need to do, if you share in the chat, that would be great. I'll do that for myself.
Okay. No, because we have
Hello.
to, yeah. Dipanjan, can you go?
One question can I ask?
Yeah, please, go ahead.
Actually, nowadays, the vaccination is going in very randomly. If first dose is Covishield and second dose is Covaxin, what will happen?
It should not be done.
It should not be done. No, never.
No.
Too different.
Okay. But by chance it is happening?
No, it cannot. It is your duty to tell that I have taken Covaxin in the first or Covishield. It is the duty of, yes.
Not going to happen.
No, it will.
Logistically cannot happen. Logistically also cannot happen because you register on the site. Site will number, you get a number.
Okay. No. Let me tell you one thing. You do not have the choice to get Covaxin or Covishield, right?
Absolutely true. Yes.
You do not have the choice. But once you are given a vaccine, you will be told that it is Covaxin or Covishield.
Yes, they're told. But in the second dose, if it is reverse.
No, it will not be. It cannot be. Because the government notification is that it cannot be given. So before they take it, they will see what was your first dose. They are giving a certificate after the first dose.
Yes.
Yeah, it is clearly written. Everything is written.
It is all registered.
Thank you.
Your ID,
Yes.
Yes. Dada, please share that thing. What test need to be done?
With all of your permission,
Just one question.
Log out. I have another meeting to starting at 9 p.m.
Okay.
So you can just continue. I request Biswajit to take over the moderators as moderator.
Okay. Yeah. Carry on.
I just have one question. Chandana.
Can I ask a question, please?
This would be the last question, please. We will have to...
I want to ask an important question. A lot has been written about it. What's the reaction of alcohol after the vaccine? Can we continue to drink or no?
It all depends how much alcohol you want to consume during the vaccination, after vaccination.
Wow.
See, jokes apart, what I mean to say is here, say more than 5 drinks, that is called a binge drink, right? I think Dr. Kaushik will agree with me. So more than 5 is what is called as binge drinking. So if you're going more than 5 or binge drinking, then you're going to get a immunosuppressed response to your vaccine. You're not going to get a full immune response. And too much of alcohol or binge drinking is a pro-inflammatory state. So that will also lead to a lesser immune response. So if you are going to have a normal alcohol intake, that's not an issue. You can go ahead and enjoy your party, enjoy your life. But higher alcohol intake post-vaccination is avoidable. Still, data is not that much. But basically, it's talking about here is binge drinking. That is on the all of theoretical aspect.
So can I ask one more question? The last one probably.
Yeah. Quick.
So for a 60-year-old who has gone on angioplasty 2 months back, is it a good time to take the vaccine, or should they wait longer?
No. Why they should wait? What is the indication for the waiting? I don't understand why to wait. If there is no contraindication per se about the blood thinner, And if that person is on acetone or warfarin, then obviously, as we discussed, INR should be less than 3. Otherwise, he should go ahead and take the vaccine. There's no contraindication per se that I can understand of to delay the vaccination. In fact, he should take the vaccine as early as possible.
Can I just tell this in short, in a nutshell? If you have seen the presentation of Kaushik, Dipanjan, and Swapnil, you will understand actually there is no severe contraindication for these vaccines. It's very simple as that. Unless a person is inherently allergic to because some of the adjuvants or other chemical substances in it. So one should not be scared that I am taking this, it will happen. Nothing is going to happen. It is just like any other flu vaccine.
Yes.
It's exactly. And you will be astonished because normal people do not see what flu is. But if you go to the CDC website, you will be able to see how many flu deaths occur in America every year. Right, Kaushik?
Yes, sir.
And how many people suffer from normal flu, that is influenza A and B?
Absolutely. I mean, I am mandated by my hospital to get my annual flu jab because I am healthy. I will get it. I'll survive. But if I transmit it to an elderly post-cardiac surgery transplant immunosuppressed patient, they'll die. So it's exactly the same ethos that it's like live and let live. You got to take the vaccine yourself for yourself and for everybody that you love who lives around you, your friends, your family. And you should encourage your friends and family to take it because this is our best bet to get back into the normal lives that we are used to living. The choice is as simple as that.
So, can I have one question last?
Dada, please, we are running short of time. We have already exceeded it.
But last I have a very...
Sure, Dada.
Actually, what I think this is probably the first adenovirus vector vaccine for human. So,
really?
First adenovirus-based vaccine for human, huh?
No.
Any other vaccine?
I think I don't know.
Yes, vaccine platform-wise, the polio virus that we use is a live attenuated live virus.
Yes, sir. That is Sevin and Sark. That is one is killed, one is live. But vector as a vector, adenovirus vector, it has some chances of implication or integration, chances of integration into the genome of a human.
It is almost non-existent. The adenoviral vector is inactivated. It just allows the virus to transfect. There is no viral genome of the adenovirus left inside that virus. So the only thing is the outer capsid protein that goes. The adenoviral transfection technology, although new and used in the vaccination field maybe for the first time, there are lots of other fields with inborn errors of metabolism that this technology, sickle cell anemia, that this technology has been tried. There are concerns. I understand your concerns, but now...
But the mRNA has to be expressed in the body, now.
mRNA will be expressed in the body, but it doesn't.
It will be under some promoters. From where that promoters they will get, either from vector or from body.
Your body. It's not the viral. Yeah, your own DNA RNA mechanism is doing it. And as far as the Pfizer and Moderna studies are concerned, I encourage you to go and you seem to be somebody who understands this. You're clearly in the field. Read the papers up. There are viral genome incorporation studies. The transfected spike protein was marked, and there is no integration into the human genome for the cell lines that were studied. These are not for every patient. So yeah, maybe down the line, somebody publishes a case report, but as of now, there is no data to support that contention that is integrated into the cell lines. And moreover, I've heard those concerns even from female colleagues of mine in the reproductive age group who are concerned that that it's going to get incorporated and it's going to be passed down the progeny as they have children. We do not have any data to support that contention as yet. That's all I can say confidently.
Thank you.
Thank you, Dada. Thank you, everyone. Ritesh Da, can you request you to have a closing remark, please?
Abhijit Da would like to share something which we got a message from our Ramakrishna Mission Lucknow Center, which itself has a good hospital. So I will request Abhijit Da to share that message, and then I will
sum up.
go for closing. Thank you.
Ritesh, we have just 6 minutes, so please be mindful
Ritesh,
of the
I
time,
think
please.
you share. Ritesh, I think you share it. The PPT last slide, you share it and close it. It is your thing.
Hi Abhijit Da, why don't you see yourself? एक बार दिखाओ अपना चेहरा एक बार दिखाओ एक बार.
Sorry.
Nobody is seeing you. এটা কি হচ্ছে?
Yeah.
আরে এত হেভি দিলে তো আলটিমেট.
Abhijit Da.
Ritesh, I think you have to share it. There is a bandwidth issue in my area, so that's why.
Okay, I'm trying to share the screen. Let me know when you can see it or not.
Yeah. Please.
Can you see the screen now?
Yes.
Yep.
So this was a message from Swami Bareshananda Debu Maharaj from Ramakrishna Mission Sevashram Lucknow. He has sent a poem in Bengali, which I have tried to translate it. So for convenience of everybody, I will read out the Bengali first. Corona ke corona bhoy, coronar bhoy te jodi bhito hoy mon, bhoy ke joy korbo mora ei moder pon. আমাদের ভয় কি আমরা অভয়ার ছেলে করব মোকাবিলা করোনা এসে গেলে দেহ নই মন নই আমরা অজয় অমর করোনার বংশ করব ধ্বংস যদি হয় সমর তবু যদি ভয় পাও শোনো বলি ভাই টিকাকরণ করে নাও অন্য পথ নাই. Don't be afraid of corona. If our mind is afraid of corona, our challenge is we will overcome fear. Why do we fear? We are sons of fearless. We will resist if corona comes. Nobody, no mind. We are immortal. We will fight and destroy corona in the war. Still, if you are afraid, brother, get vaccinated. No other alternative. I think that's the best summation. Get vaccinated. No other alternative. That is the theme of this discussion. Now, Ritesh will sum up. Thank you.
দারুণ বলেছে মানুষ.
দারুণ.
Thank you, Abhijit Da.
জয় ঠাকুর.
Thanks very much to Dr. Biswajit Sen or Biswajit Da, Dr. Kaushik Mandal or Kaushik Da, Dr. Swapil Gautam. He's my junior, so I will take the liberty of calling him Swapil. And Dr. Dipanjan Haldar. I will call him Dipanjan. On behalf of Vidyapit family, Praktani, and the audience, a very big thank you for investing your time in speaking on a topic which is very relevant to us. Apart from that, it shows the bond we are developing as in the Praktani. It also shows the dedication you have not only for the Praktani but society as a whole. That's why we shared this invitation to around 200 centers in Ramakrishna Mission, and one of Maharaj from Haridwar, who himself is a doctor, is in the audience. And I request the questions which we couldn't take or which comes in the future, we will forward you those queries and you can interact with the people who have asked those questions. And also thanks to the team of EC, particularly Rahul, both Rahul Shubham and Rahul Rakesh, who are with the help of this digital media, made these things possible. And I hope we will carry on with these monthly talks, which will be interesting and help our family. So the next talk is on cosmology by one of our juniors. He's based in France. A very interesting talk because he studies the surface of universe. We will be sending the invitation for the next month, and hopefully you or your family or your kids who are interested in physics or cosmology may be able to attend it. And thanks to Abhijit for always, funny and entertaining and making the atmosphere light for all of us. Thank you very much.
Thank you.
Thank you. Thank you.
Yes, ধন্যবাদ। আমি সবচেয়ে সিনিয়র 1972 ব্যাচ।
থ্যাংক ইউ।
এই চারজন ডাক্তারের কাছে আমি চিরকৃতজ্ঞ। ভালো লাগলো তোমাদের কথা।
Thank you.
ভালো লাগলো। Thank you. Lot of thanks. Lot of thanks to Rahul and Obiju.
Thank you, Dada.
Thank you. Thank you, Biswajit.
Thank you, everybody. I'll be leaving.
Yes, Biswajit, cheers.
Cheers. পরে আবার দেখা হবে।
Yes.